Hi, I am Dr. Rajiv. Today we are going to discuss ACLS, some basic concepts. Okay, so what we see, what happens, first when we see a patient, suppose when we see a patient, basically what is the first response is like initial impression. Okay, so initial impression, that means the patient is either unconscious or the patient is conscious. Okay, so this is our first impression what we see in our patient. Okay, and it is very important to see, like if the patient is unconscious, we will do BLS assessment. Okay, and if the patient is conscious, we do BLS assessment. We'll try to make the patient conscious. Okay, and then suppose if the patient is conscious from before or after doing the BLS assessment, we made the patient conscious, we do the primary assessment. And after doing the primary assessment, we go for the secondary assessment. So what happened in BLS assessment, primary assessment and secondary assessment, we will discuss later. Okay, so we'll discuss this BLS assessment, primary assessment and secondary assessment in a different video. Okay, so ACLS full form is the Advanced Cardiovascular Life Support, right? So when we see a patient, basically we will secure the scene in the BLS assessment. We will secure the scene. These are very basic things to understand. We have to secure the scene safety, and then we will recognize whether there is a cardiac arrest or not. We recognize, we check for breathing, we check for pulse. So there will be no breathing, maybe gasping. Okay, there will be no definite pulse in we'll see till 10 seconds. If there will be no pulse, okay, so we will start with the CPR. So the primary objective is to do compressions. Okay, so we start compression when no pulse is felt. This is our first thing to understand. Okay, now as a doctor present there, we will check for respiration, is breathing is there or not. Okay, but before that, we have to first see pulse is there, respiratory there, no, it's not there. Okay, so we will call for help. We will activate the emergency system. We will activate emergency response system. Okay, we'll do a call. Okay, so in US we do 911. In India we call the nearest hospital. Okay, so 108 ambulance maybe, right? Now what happens, we'll start with the compression, and the compression to respiration. If I am alone, the compression to respiration for adults is 30:2. Okay, for children and neonates that is different, but we are not going there. So 30:2. Even if there are two, I got a help from someone, so still the compression to respiration is 30:2. If there is no ambu bag present in COVID era, we are avoiding respiration at all. Okay, if the bag and mask is present, then only we will do the respiration. Otherwise we will just continue with the compression till we, and for how many minutes, like compression till 2 minutes, and after doing compression for 2 minutes, we will check for the pulse. If there is still no pulse, we'll start the compressions again. Make sure that this intervening time, this time does not exceed more than 10 seconds. So 10 seconds is the minimum. Now about compression, I want to say a few more words. Like compression should be, like about 2 inches or 5 centimeter deep. So suppose this is a body, right? So the compression should be at least 2 centimeter. So we are actually doing the work of the heart. Okay, so whatever the thing we have, whatever the oxygenated blood we have in the arteries and veins, we are trying to do the heart's work and circulate to the major organs, especially brain. Okay, and at the heart itself. So this is 1/3. In child we have around and pediatric age group we have a different system. Like we say 1/3 of the chest should be compressed. Okay, so we'll start with the CPR. Yes, we start with the CPR. We will check the SpO2. if the SpO2 is nearly less than around say 90 to 95%, okay, we'll give oxygen. If there is no oxygen, we don't give anything, right? Now, being in ACLS, we always we see that we are basically the leader in that point, right? So being a leader, I have to assign works, assign duties. Okay, so suppose I called for help. Before that, I was doing the CPR on my own. My team arrives. Okay, so suppose 6 to 8 people are there. In this 6 to 8 people, I'll assign that one go for defibrillation. Okay, I'll assign by names. I'll say A, you go and do the defibrillation. Okay, suppose B, I'll say okay, you are the compressor, you take my position and start doing compressions. Okay, so for 2 minutes I am secure that compression is still going on, right? Now after compression, what we have to give, if bag and mask has also arrived, so we have to give breathing, airway, right? So when I'll assign another person for airway or the bag and mask, airway breathing, we'll go for the bag and mask. Okay, so bag and mask will be there, bag and mask. Okay, now suppose another person will do, I will assign another person to maintain time period. Okay, maintain time for the whole thing which is going on. Okay, so the initial time will be first when I see the monitor, what is the ECG rhythm, that is the first reading. Okay, now after that what will happen, I'll assign someone to do IV access. Okay, and to get ready for the drugs also. Okay, so I'll assign someone, and basically the fifth one is he could be the coach, the CPR coach. Okay, so the main objective to assign a CPR coach, the concept has came recently only. The CPR coach will check the quality of CPR, okay, the quality of CPR. So what is quality of CPR? So these are the points for the quality of CPR. That is the push hard and fast. Push hard at least 2 inches, that is 5 centimeter, and fast, that is 100 to 120 per minute, and allow complete chest recoil so that the blood will return to the heart and coronary perfusion will be there and heart will not get very fatigued. Okay, so this is the first quality of the CPR, a good quality. Minimum interruption in compression, I told you that whatever the if you are monitoring or giving defibrillation, we should always do within 10 seconds, not 10 minutes, 10 seconds. Okay, less than 10 seconds. So interruption should be always less than 10 seconds. Now avoid excessive ventilation. Yes, we avoid excessive ventilation because it may cause increase in the intrathoracic pressure. Okay, and it may cause gastric insufflations. So there are many demerits of the excessive ventilation. Okay, so suppose we have a bag and mask. We'll make a bag and mask like this. We'll make a bag and mask, right? So in this bag and mask is nearly 1.2 liters. What is our tidal volume? It is around 500 ml, right? So what happens, this we don't have to compress it fully, we have to compress just half of it. That will check whether we are doing excessive ventilation or not. Okay, we don't have to rush, right? Now if no advanced airway is present, 30:2 compression by ventilation ratio we have discussed, and if the monitor is attached, we'll check the waveform capnography. So this kind of waveform capnography will be there. Okay, so this shows the normal is around 30 to 40 mm, this height. Okay, so if there is a cardiac arrest, there is 0 mmHg, there will be no flat line in the because this capnography, what we see, the extubated what we say, मतलब कितना CO2 बाहर आ रहा है. Okay, तो expirated CO2 we measure. There is a monitor which measures the expirated CO2. So in the patient when it is in cardiac arrest, there is no pulse, no cardiac activity, no respiration, so the CO2 will be zero, right? Now when we start compression, when we start doing compression, the best compressions will give you a capnography of around half, now nearly 20 mmHg, nearly 20 mmHg. That is our target. Okay, so we achieve 15 to 20 around during our compression to see the quality of compression, quality of the CPR, right? So quality of the CPR. So this is the work of the CPR coach. This is a very new concept and very important concept. Now, in IV, when we asked the person to do IV line, so we also can do IO if IV is not, the patient is in shock maybe. If IV is there, okay, we ask the person who is actually doing this IV channel, we'll ask her or him to get the blood, and we run for the ABG. We run for the ABG. Now this ABG will actually give you two things basically. First, what is the normal potassium level is there or not, or and also it will give you this acidosis is present or not. Acidosis is present or not. Why I am emphasizing on this point? Because we should know what are the reversible causes. What are the reversible causes of cardiac arrest? We should know about the reversible causes of cardiac arrest. Okay, so what are the reversible causes? So there are 5H and 5Ts. 5H and 5Ts. So 5H, that is hypovolemia. So hypovolemia, yes, so it can be corrected by giving IV fluids. Okay, so IV channel करने के बाद क्या करेंगे? Normal saline चढ़ा देंगे, ठीक है, at a bit mild to faster rate, ठीक है. तो हम लोग बोलते हैं around 10 to 16 drops per minute, या even more than that. Okay, but we have to see if the patient is renal compromised. We will never start giving the normal saline, because it will the patient will be volume overload, fluid overload problem may be there, right? Now also after in the ABG we'll confirm whether we can give ringal lactate or not, even the other to prevent the lactic acidosis. Okay, hypoxia, will see the saturation, okay, and we'll give oxygen as per required. Then we'll correct the acidosis by giving sodium bicarbonate, right? Now if there is hypokalemia or hyperkalemia, there we see. So if there is a hypokalemia, if the patient is conscious, no. If the patient is not conscious, we will give injectable KCl. Otherwise we can give potassium pot chlor, we say potassium. Then we will correct the magnesium also. In the hyperkalemia, we give dextrose with insulin. Also we can give calcium gluconate. Okay, now in hypothermia we'll check the temperature. If there is hypothermia, we'll arrange in that way, right? Now there are T's, that is tension pneumothorax and cardiac tamponades, very important. Toxin will see in the color. We expose the patient and we see the color. So whatever the thing, the first thing we should know, like we do the assessment, right? When we do the assessment, there is a part of exposuring the patient, and we analyze what the patient is actually maybe having, what may be the cause of this. Okay, the diagnosis. Because BLS, the patient is nearly secure. If the patient is not secure, then we'll actually secure the patient first. We'll secure the ABCs, right? So what is the primary thing I want to discuss right now? That is, after BLS we do the primary assessment. So in the primary assessment there is A, B, C, D, E. So A for airway, breathing, circulation, here comes the IV thing, right? D for disability check, is there any disability, and E for exposure. Okay, and there is something called secondary assessment. Here we go for the differential diagnosis, and there we go for many other things, right? We'll discuss later. So basically what will happen if we get a patient of cardiac arrest, and suppose we see a patient with a cardiac arrest, and we will attach monitors, we'll attach the defibrillator, we have assigned for defibrillation person, we are continuing with the CPR. Now we'll check the monitor, the leader. Suppose I am the leader, I'll see whether the rhythm is shockable or not. So what do you mean by rhythm is shockable or not? The rhythm of ventricular fibrillation, suppose this kind of fibrillation, ventricular fibrillation we can see, right? Or pulseless ventricular tachycardia. If suppose there is a ventricular tachycardia but there is no pulse, right? There is no pulse. So will be ready for the shock. So a shock, what is the concept of shock? A shock energy for defibrillation is actually we try to give the maximum, that is the 360 joule. 360 it will be you can see, and whatever the maximum you can give. The basic idea of giving shock is to stop the heart whatever it's doing, right? So it can be monophasic or biphasic. Biphasic basically in a body we see. So suppose this is our heart, so we'll place a pad over here and we place a pad over here. What do we mean by here and there? This one position and two position. This one position is basically below the clavicle, so the clavicle will be here and we'll place it below the clavicle. Everything whatever I'm saying will be written on the pad itself, where to place the pad, right? And the second is around the axillary line. So the second will be around the axillary line below the nipple of the so the main concept is to keep the heart between the pads. The main concept is to keep the heart between the pads. Okay, so we give a shock. Okay, we give a shock, and we, as soon as the shock has been given, the compressors. Okay, there are things like before giving shock, we have to say that we have to clear. Nobody should actually give the compression or or breathing. We have to charge it, so we have to be ready with the charge. We have to give as soon as possible. Now if the shock is given, okay, we resume the CPR as soon as possible, and this is the duty of the CPR coach and the leader to see that the CPR is effective and it starts as soon as possible. Okay, so after doing that compressions and all, we get the IV access over here. Okay, and we get the blood for the ABGs. We'll send for the ABGs. Again, after 2 minutes, what we see, we check the monitor and see whether the rhythm is shockable or not. Okay, if the rhythm is suppose again shockable, yes, what will give the shock, will say clear. Okay, everybody clear, and then we give the shock and start the CPR again. Okay, so the compressor should hold this, both hands just above the chest. So whenever the, suppose this is the sternum, this is the Jiffy sternum. Okay, so this Jiffy sternum, we have to place our hand in between here. Okay, and so what happens, so just after giving shock, the compressor will keep our hand just above it. Okay, and it will restart the compression as soon as possible. As soon as possible means just start giving the shock, will start the CPR for 2 minutes. We don't see monitor, we don't see pulse, we don't see anything. We go do the CPR for 2 minutes, and after giving first shock was this, second shock was this. After giving second shock, okay, we give epinephrine. I will advise the person who is responsible for IV to get ready with the epinephrine 1 milligram. So what is the drugs dose? So this is the epinephrine 1 milligram every 3 to 5 minutes, and we'll see about amiodarone and lidocaine. That is around, the amiodarone first dose is 300 milligram and second dose 150 milligram. Okay, so whether we can use amiodarone or we can use lidocaine, either of the two, but epinephrine, it should be continued every alternative CPR cycle. Okay, I'll say how. Now see, suppose this is the second shock given, epinephrine first dose given over here, right? Now again, suppose we check after 2 minutes that we check whether the rhythm is shockable or not. Suppose the rhythm is still shockable, right? If the rhythm is still shockable, we again we give the shock, we do the CPR, we restart the CPR, but we do not give epinephrine over here, we give amiodarone. First dose is around 300 and the second dose is half of it, that is 150 milligram. Suppose we give lidocaine, it is 1 to 1.5 milligram per kg, and in the second dose it is half, that is 0.5 to 0.7 milligram per kg. Okay, so suppose what happens after giving amiodarone first dose, amiodarone we gave epinephrine, this the person who is doing the chart, okay, we will write like this: when it was started, when it was started, when was epinephrine given, again a shock was given, then again what happens, again amiodarone is given, suppose a shock is given over here also. So after giving first shock, we don't give any drugs, we do the IV channel. Okay, after giving second shock, we give the epinephrine. After giving third shock, we give the amiodarone 300. Now the 3 to 5 minutes are over. After giving shock again, we give epinephrine. If not revive again, we give another shock and then we give an amiodarone 150. Okay, okay, then again we give a shock, then we go for epinephrine. So epinephrine will be given in the alternate, you can see we will given in the alternate CPR cycle. Okay, now amiodarone only 2 doses, not more. यहाँ पे फिर amiodarone नहीं देना, फिर से amiodarone नहीं देना, epinephrine कंटिन्यू करते रहना. कब तक करना है कोई गाइडलाइंस नहीं है, यू कैन डू एज मच एज पॉसिबल, CPR करते रहिए आप. ठीक है, सपोज आर रिदम amiodarone 150 देने के बाद जब मैंने दोबारा फिर epinephrine दिया, तो epinephrine देने के बाद तुरंत क्या हुआ, सपोज रिदम जो था एक सेकेंड रुकिए ना, रिदम जो था वो शॉकेबल नहीं रहा. रिदम क्या हो गया, आपको इस तरह से एक नॉर्मल पी वेव मिल रहा है, सॉरी नॉर्मल PQRS, पूरा एक नॉर्मल जो रिदम है वो आपको मिल रहा है. ठीक है, आपको मॉनिटर में ये दिखा, यू आर हैप्पी, यू आर वेरी वेरी हैप्पी कि आपको मिल गया. बट द थिंग इज दैट व्हेन यू चेक फॉर द पल्स, देयर इज़ नो पल्स. अब ये क्या हो गया कि यहाँ पे तो दिख रहा है हम लोग को मॉनिटर में, बट यहाँ पे कोई पल्स है ही नहीं. तो इसका मतलब व्हाट हैपेंड एक्चुअली, दिस इज़ नथिंग बट पल्सलेस इलेक्ट्रिकल एक्टिविटी. So the heart is actually started, but the thing is that it is actually giving up a rhythm within itself, but it has not started pumping, it has not doing any activity. Already the electrical activity is there in the heart. Okay, so this is nothing but the pulseless electrical activity. Okay, or we can say that it will be like this, and then it will be like this, like it will be asystole, it will be asystole or pulseless electrical activity. If it happens, what we'll see, we have to give epinephrine as soon as possible. Okay, we have to give epinephrine because we have done this IV channel and all. We will give epinephrine again. Okay, and we'll start with the CPR as soon as possible again. ठीक है, तो अब CPR करना है, पल्स चेक करना है, नहीं CPR करना है, उसके बाद फिर देखना है कि रिदम कैसा है. ठीक है, अगर रिदम शॉकेबल है तो फिर उसके बाद हम लोग क्या करेंगे, शॉकेबल फिर से हम लोग बना दिए उसको रिदम को, तो हम लोग 5 और 7 को रिपीट करेंगे, मतलब ये वाला पोर्शन CPR देंगे, एपिनेफ्रिन देंगे, amiodarone देंगे फिर से. ठीक है, लेकिन अगर रिदम शॉकेबल नहीं है तो हम लोग CPR देते रहेंगे, और जितने भी हमारे अब ABG का रिपोर्ट तब तक आ जाएगा तो रिवर्सिबल जितने भी कॉजेज़ थे उसको हम लोग ट्रीट करना शुरू करेंगे. ठीक है, ट्रीट करना शुरू करेंगे. दिस इज़ वेरी वेरी इंपॉर्टेंट कि हम लोग को जानना होगा कि जब तक हम लोग का रिदम जो है नॉर्मल नहीं आता है, पल्स नॉर्मली नहीं आता है, ब्रीदिंग वो खुद से नहीं करता है. ठीक है, तो हम लोग देख रहे थे कि यहाँ पे जो हम लोग ये कर रहे थे आपका कैप्नोग्राफी में, वो ऐसे आपका एक वेव्स आ रहा था. ठीक है, इट वाज अराउंड 20. ठीक है, तो ये कंप्रेशन के चलते आ रहा है. ठीक है, ये कंप्रेशन के चलते आ रहा है, ऐसे करके आता है. ठीक है, साउथ इंडियन जो पुलिस होते हैं वो इस तरह की टोपी पहनते हैं, अगर आपने ध्यान दिया होगा तो. ठीक है, राइट, इस तरह के टोपी पहनते हैं ना, ठीक है, तो सर स्लाइटली ये रहता है, टर्न रहता है। तो अब ये दिस इज द नॉर्मल, तो अब ये 20 है, ठीक है। अचानक से आपने क्या देखा कि यहाँ पे 40 आ गया, तो 40 आ गया तो रिटर्न हो गया, हमारा नॉर्मल कैप्नोग्राफी आ गया। तो इसको हम लोग बोलते हैं ROSC। ROSC मतलब क्या होता है? रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन, रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन। और जहाँ रिटर्न ऑफ स्पॉन्टेनियस सर्कुलेशन आ जाता है, ठीक है, अगर आ जाता है तो पोस्ट कार्डियक अरेस्ट केयर हम लोग स्टार्ट कर देंगे। अगर नहीं आता है तो रिससिटेशन को हमको कंटिन्यू करना पड़ेगा। तो व्हाट इज पोस्ट कार्डियक एडल्ट पोस्ट कार्डियक अरेस्ट एल्गोरिदम? वहाँ पे बोला जा रहा है कि यहाँ रिटर्न ऑफ द स्पॉन्टेनियस सर्कुलेशन, और वहाँ पे अगर ये आ जाता है, देयर आर इनिशियल स्टेबलाइजेशन फेज में ये चीज़ हम लोग देख रहे हैं कि ऐसा करके दिख रहा है, तो हम लोग वहाँ पे फिर से ABC कंटिन्यू करेंगे। मेंटेन एयरवे, अब हम लोग क्या करेंगे? एंडोट्रेकियल ट्यूब वहाँ पे प्लेस करेंगे। वी विल सी द रेस्पिरेटरी पैरामीटर्स लाइक 10 ब्रेथ्स है कि नहीं, SpO2 इज़ विद इन 92 to 98% है कि नहीं, PaCO2 इज़ 35 to 45 mmHg है कि नहीं, एंड देन विल गो फॉर द BP मेजरमेंट। विल आस्क फॉर द BP है कि नहीं, कितना है वहाँ पे। तो आर टारगेट इज़ मोर देन 90, आर टारगेट इज सिस्टोलिक मोर देन 90, ठीक है। ये बहुत इंपॉर्टेंट है। उसके बाद एज सुन एज पॉसिबल हम लोग फिर से एक 12 लीड ECG चेक करेंगे, कहीं कोई फॉल्स रिजल्ट तो हमारा नहीं आ रहा है। वो करने के बाद हम लोग क्या करेंगे? हमारे कार्डियोलॉजिस्ट को इन्फॉर्म करेंगे, स्टेमी प्रेजेंट है कि नहीं चेक करेंगे ECG में, कोई शॉक इस तरह का प्रेजेंट है कि नहीं, और यहाँ पे मैकेनिकल सपोर्ट ज़रूरत है कि नहीं वो देखेंगे। और वहाँ पे सबसे इंपॉर्टेंट चीज़ आता है कि पेशेंट इज़ अवेक, वेरी गुड। अगर पेशेंट अवेक है तो उसको हम लोग क्या करेंगे? आगे के इंटरवेंशंस के लिए कार्डियोलॉजिस्ट के पास भेज देंगे, ICU केयर में, ठीक है, और वहाँ पे CCU केयर में, सॉरी, ठीक है। और वहाँ पे अगर कमांड फॉलो नहीं कर रहा है तो पेशेंट स्टिल कोमाटोज, तो कोमाटोज हो जाएगा। हम लोग को फिर भी अगर ROSC मिल चुका है बट पेशेंट स्टिल कोमाटोज, हम लोग क्या करेंगे? हम लोग इन्फॉर्म करेंगे टू द कार्डियोलॉजिस्ट, विल डू द EEG मॉनिटरिंग और CT स्कैन, ब्रेन CT करने की कोशिश करेंगे अगर मिलता है कि नहीं, ठीक है। और यहाँ बहुत इंपॉर्टेंट है TTM। तो व्हाट इज TTM? इट इज़ टारगेटेड टेम्परेचर मैनेजमेंट, इट इज़ टारगेटेड टेम्परेचर मैनेजमेंट। और यहाँ पे आपको देखना होगा कि यहाँ पे उसका जो ये है आपका टेम्परेचर है वो 32 to 36 डिग्री सेल्सियस फॉर 24 आवर्स हम लोग मेंटेन करने का कोशिश करेंगे, ठीक है। क्रिटिकल केयर मैनेजमेंट अलग से क्या हो सकता है? तो हम लोग का मतलब टेम्परेचर, कोर टेम्परेचर को मॉनिटर करेंगे, इसोफेजियल रेक्टल टेम्परेचर है कि नहीं सही से, नॉर्मोक्सिया ऑक्सीजन क्लियर है कि नहीं, कार्बन डाइऑक्साइड क्लियर है कि नहीं, शुगर देखना बहुत ज़रूरी होता है, ठीक है। हम लोग स्टार्टिंग में ही इवैल्यूएशन करने के समय, असेसमेंट करने के समय हम लोग शुगर चेक करेंगे, ठीक है। EEG देखेंगे है कि नहीं, राइट। वो सब करने के बाद हम लोग को बेसिकली पेशेंट को शिफ्ट कर देना है। और एट द एंड ऑफ द डे हमारे पास जितने भी लोग हमारे साथ काम कर रहे थे, सपोज वी हैव 6 पीपल, तो सबको हम लोग क्या करेंगे? डीब्रीफ करेंगे। डीब्रीफ करने का मेन फंक्शन क्या है कि नेक्स्ट टाइम अगर इस तरह का कुछ आएगा हमारे में स्क्रूटिनाइज करेंगे, तो मतलब एक तरह से कि क्या सही था, क्या गलत था, ठीक है। फिर एक इंसान हम लोग का पूरा चार्ट मेंटेन कर रहा था, उस चार्ट को इवैल्यूएट करेंगे, ठीक है। फिर एक जो है आपका जो CPR कोच थे, वो जब जितना देर CPR चला उसको देखेंगे, तो वहाँ पे हम लोग को एक फ्रैक्शन मिलता है, एंड दैट फ्रैक्शन वी विल सी कि हमारा पूरा जो प्रोसेस था वो कितना अच्छा रहा, ठीक है। तो ये इंपॉर्टेंट है आपको जानना, ठीक है, कि डीब्रीफिंग इज़ वेरी इंपॉर्टेंट, कि नेक्स्ट जो भी होगा उसके लिए हम लोग रेडी रहेंगे, ठीक है। और इट इज़ ऑलवेज अ टीम वर्क। हम लोग को अपना जो टीम है उसको बहुत अच्छा से, इट शुड, दे हैव टू बी ACLS ट्रेंड, अगर नहीं है एटलीस्ट BLS ट्रेंड रहेंगे। तो द लीडर का काम ये रहेगा कि ही इज़ ACLS ट्रेंड, ही शुड बी डायरेक्टिंग एवरीथिंग पूरा। अच्छा, एक चीज़ मैं और बताना चाहूँगा यहाँ पे, क्लोज लूप कम्युनिकेशन। क्लोज लूप कम्युनिकेशन क्या चीज़ होता है कि यहाँ पे अगर आप मान लीजिए कि मैंने एक स्टेटमेंट दिया कि आप आप एड्रेनालिन एपिनेफ्रिन 1 मिलीग्राम IV रेडी रखिए। सो द नर्स, और या जिसको मैंने बोला है, शी और ही शुड रिपीट द स्टेटमेंट कि मुझे 1 मिलीग्राम IV एपिनेफ्रिन रेडी रखना है IV देने के लिए, ठीक है। फिर मैंने बोला आप उसको दे दो, 1 मिलीग्राम एपिनेफ्रिन दे दीजिए, तो वो बोलेगा कि नाउ आई एम गिविंग 1 मिलीग्राम एपिनेफ्रिन IV आई एम गिवन, ठीक है। वो चीज़ क्लियर करना होगा, ठीक है। तो ये क्या हो रहा है, एक छोटा सा लूप में जो मैं बोल रहा हूँ वही चीज़ वो रिपीट कर रहा है, राइट। तो क्या हो रहा है, ये एक क्लोज्ड लूप कम्युनिकेशन इसको कहते हैं, एंड दिस इज़ वेरी वेरी इंपॉर्टेंट इन एनी दिस सेटअप, ACLS सेटअप में ये बहुत इंपॉर्टेंट होता है. ओके, सो विल सी यू इन द नेक्स्ट वीडियो. आई होप यू लाइक द वीडियो. थैंक यू.